Thanks, Claire, for inviting me into this podcast. I must say at the outset, this is my first experience at filming, so there'll be lots of stuttering, stammering, so just put up with me, please. I know you're all accountants, so I shall give you a brief description of my role. I was appointed as Clinical Director for Performance and SLR about 15 months ago now. It started after I'd done a few managerial posts, and my remit is to get clinical engagement in the whole concept of SLR and teams. So we've got an ambitious project which over the next 12-18 months should deliver several clinical teams working together with SLR and developing their own quality matrices. To answer that question, perhaps we need to rewind back a little bit. Historically, doctors are highly motivated, driven people. Having reached, if you like, the level of a consultant, that would have not been easy to achieve. Having said that, quality and performance is very close to clinicians. So any accurate representation of their performance will immediately get their full attention. I can tell you perhaps what not to do, and then answer your question directly. There's no use taking a whole bunch of information to a clinician about statistics, about losses made or profits made, etc., without these numbers having been validated before. If there's anything that would really drive a clinician up the wall is for somebody to bring numbers which he or she is not familiar with. So I would say the first meeting should be about what are the common goals that we wish to achieve. What is the direction of travel between the clinician and the accountant? You can start off with gross numbers. Do you feel that these are accurate? For example, you are seeing X number of news a month. These are the numbers we have in our books. Do you feel that this is accurate? Maybe a starting question. It is easily possible to be more precise on that because all systems in the hospital will measure new outpatient episodes, so one can begin to gain the confidence by bringing these numbers out. The challenge begins once you start going into SLR, tariff, profit, loss, etc., because there are a lot of assumptions made in the SLR model. Theatre costings, cost of x-rays are all models. Now, it is easy for a group of people to design this model without the clinicians being involved in it. I'll give you one example. The SLR costed a procedure where we use an image intensifier to do an injection into the joint at a few £100. Now, clinicians looking at it said, why is it costing that much? There's no radiographer involved. The clinician is the one who is operating the machine. And yet the SLR said that procedure cost several £100 and the tariff for that was, hardly meeting the cost. It became evident that the assumption made in the model was needing to be looked at because the cost of the lease of the machine for a few minutes just drove the SLR model completely untangible. But there was no clinician involved initially in that discussion. And once the clinician sees this model and he starts saying, oh, is this what it costs? Then he say, I'll go outside and do it. Or very rebellious comments are likely to originate from the clinician. So I would suggest that we start from square one, really, building up the relationship with the clinician, starting with simple, understandable numbers, and then building it up to complicated Excel spreadsheets, which I know run the SLR database. In theatres, which is probably the engine of any surgical department, that's where all the activity happens, and most of the expenditure also happens there, it is very important to get a model that is acceptable to all. The model should clearly reflect that somebody who performs better is actually rewarded rather than penalized. So, for example, you could have a model that determines unit of usage of theatre time in minutes. So I could come into the hospital, operate for 100 minutes, and I could get a bill for those 100 minutes. On the other hand, the rest of the day has been wasted, and the person who's working 800 minutes trying to drive more cases is actually penalized for having done more. So this model immediately sounds unfair to surgeons, but working with the theatre staff and the clinicians, it is possible to come to an agreeable model, which is what we have achieved in WWL. The other big area in theatres is consumables. There's currently no driver for a surgeon to try and perhaps save a fiver or a tenner on a drape, or even £100 on kit that he or she can use. In our theatre model, the consumables are all aggregated together and divided per patient. So there's absolutely no motivation for me as a surgeon to change. However, moving on to our project, where we are going to go down to patient level costings, where like Bupa, each patient will have a bill of what they have used. That will then be made available on a weekly or monthly basis to the surgeon. And I'm sure lots of questions will be asked as to why some people are using certain equipment or kit. And I think a lot of efficiencies can be made in that model, as we have seen in other trusts. I mean, that is actually a very exciting prospect for clinicians who are actively engaged in this to move towards SLM. SLR can broadly be seen as a big costing exercise with assumptions made in it, which ultimately project some potentially artificial profits and losses. Whereas moving towards SLM brings in the whole remit of performance and quality into a clinician's role in the hospital. I think that is very exciting. I doubt very much there'll be any clinician in this NHS who would not want to be challenged on his quality. We are all proud clinicians that we are performing a good service. When it comes to costs, most clinicians are perhaps not that engaged. They'd rather spend the money and worry about the profit or loss later. But SLM, I think, will be the forefront of the way NHS can drive performance and costs.